الرحيم. صباح الخير دكتور عبد العزيز، الحقيقة مفتقدينك. إن شاء الله تكون بخير وأمورك تكون طيبة. Thanks for Sanofi for inviting me to share in a very important topic. Actually زي ما بيقولوا دايما الفريضة الغائبة. Cancer thrombosis in cancer patient is a very crucial topic that should be touched very thoroughly. Why? Let us start with a daily case that we are seeing every day. This 67 years old man receiving palliative chemotherapy for metastatic colon carcinoma is admitted to the emergency room complaining of dyspnea, pleuritic chest pain. He undergo chest CT pulmonary angiogram, which confirms the diagnosis of pulmonary embolism. Why this happened? Let us go back more than 20 years ago when Dr. Troze first prescribed that I have been stuck with frequency, which with cancerous patients are affected with painful edema of the superior or inferior extremity. Actually, this was explained on to Dr. Troze himself when he later on in 1860 found to have the same sign in himself and subsequently diagnosed with gastric carcinoma, and he soon died after that. Yes, vascular thromboembolism and cancer epidemiology, about 20% of cancer patients will develop vascular thromboembolism, and of all cancer patients, 20% will have symptomatic vascular thromboembolism. So as a matter of fact, 50% of vascular thromboembolism was found at autopsy compared with patient who doesn't have cancer. So there is high risk of the first of recurrent vascular thromboembolism, more than threefold, higher risk of bleeding and higher risk of dying because of the vascular thromboembolism. So vascular thromboembolism is the leading cause of death in cancer patient. Usually I ask my student in the exam, what is the cause of death in cancer patient? And usually they said cancer. Actually, cancer may be the cause of the disease, but the actual cause of the disease is usually infection, hemorrhage, and embolism. Embolism is the second cause of death in cancer patient. The incidence of cancer-associated thrombosis is increasing. If you look at this chart, you will find that a non-cancer patient will have almost a steady risk for development of vascular thromboembolism, while the cancer patient have increasing the risk of cancer thromboembolism, and this increase is not because of the increase of the incidence, but because of our orientation of the risk of vascular thromboembolism and the diagnosis. And we are expected to see more cases of vascular thromboembolism. Why? Because there are three triad change in conservation. This related to stasis, vascular injury, and a change in blood composition. Stasis with alteration in the normal blood flow because of prolonged bed rest and immobility, surgical procedure, extrinsic compression, and increased blood viscosity. And a change in the blood composition, there is cancer itself initiate the procoagulability due to hypoxia and inflammation. The more hypoxia the patient have because of his cancer, he will have more higher coagulability. Microparticles with the tissue factors and the pre-angiogenic factors, and increase overall platelet activity, and decrease in the anticoagulant activity, and decrease fibrinolytic activity. Also vascular injury due to invasion of the tumor, prolonged use of chemotherapeutic agent, endothelial damage by chemotherapy, and effect of tumor cytokines on vascular endothelium. So the risk factors are related to the cancer, to the treatment, to the biomarker, and the patient himself. The risk factor could be the primary site of the cancer, the histology, the grade, and the treatment, the surgery, the need for hospitalization, the chemotherapy, the anti-angiogenic, and the need for transfusion. Biomarker, platelet count, high platelet count, leukocytic count, hemoglobin, low hemoglobin level, tissue factor, high level of D-dimer, and thrombin generating potential. Patient-related factor related to the age, the ethnicity, and the comorbidity. The risk for the development of vascular thromboembolism is increased with the type of malignancy, with the highest risk in about 30% of the cases in hematological malignancy, about 22% in lung cancer. The less risk are with prostate cancer and ENT cancer. Also, with the progression of the disease, we have higher risk of for development of cancer. And as you can see here, as we all know, that cancer pancreas has the highest risk of GI cancer that can develop vascular thromboembolism, and this risk increase with in the metastatic situation. It is far higher in metastatic situation compared with only regional stage. This is the course by time for the risk of development of thrombosis in patient with cancer, and this early at the time of diagnosis, this increased with age. The hospitalization show a curve. The initiation of chemotherapy is associated with the risk. When the patient gets in remission, he has marked decline for the risk of thrombosis. But with the activation of the reactivation of the disease and the development of metastasis, the risk of thrombosis is markedly increased, and this could end up with death. So there is about 3 to 6-fold increase with the risk of vascular thromboembolism, and this risk factor is an ongoing process with the progression of the disease and the addition of treatment lines. The occult cancer in unprovoked venous thromboembolism. Unprovoked thromboembolism may be the earliest sign of cancer, and this is very crucial to consider in patient, especially in elderly patient. Up to 10% of patients will be diagnosed with cancer in the year after diagnosis of vascular thromboembolism. More than 60% of occult cancer are diagnosed shortly after diagnosis of unprovoked vascular thromboembolism. What is the influence on patient prognosis? A blood clot in the pulmonary artery. How this affect the outcome? As I mentioned, it is the second leading cause of death in cancer patients, and it associated with 70% of cancer progression, 9% with infection. Risk of bleeding is high, respiratory failure is high, and overall it accounts for 9% of all deaths. It is associated with early mortality during chemotherapy, more than about 7-fold risk for development of mortality associated with chemotherapy. About 47-fold increase of mortality from vascular thromboembolism compared with non-cancer patients. Why we should care? Because, as a matter of fact, it affects the survival of the patient. The vascular thromboembolism has marked impact on the mortality of the patient. It is an independent risk factor for mortality very early during the first 4 cycles of chemotherapy in cancer patients of all stages. So we have to be alert whenever we are assessing a patient receiving chemotherapy, especially in the early cycles. And this is a very important analysis of the risk of death in patients with vascular thromboembolism and malignancy of about more than 1 million patients in the Medicare series of age more than 65 years admitted to the hospital with malignancy. The cumulative probability of death within the first 183 days of initial hospitalization was about 9 fold compared to with patient who doesn't have malignancy, and this is very crucial. So what is the optimal management of this patient? As a matter of fact, anticoagulation is a cornerstone in the treatment of vascular thromboembolism. But which anticoagulant? Shall we use the oral anticoagulant, or we have to consider the low molecular weight heparin? I think the answer comes from here. This is a very important trial, CLOT trial, which compare the probability of recurrence of vascular thromboembolism for patient receiving for vitamin K antagonist oral compared to with delta brain injection, low molecular weight heparin, and there was a significant difference with risk reduction about 50%, and it was quite significant difference. The association of major bleeding is higher in patients who may receive the vascular vitamin K oral anticoagulant and compared with injection low molecular weight heparin. And also the incidence of recurrence is markedly higher in patients receiving warfarin compared to with patients just receiving low molecular weight heparin. The hazard ratio is 0.65. The major bleeding, again, as I mentioned, is higher with in patient receiving warfarin compared to patient receiving low molecular weight heparin. And this is meta-analysis of the low molecular weight heparin showed better than vitamin K agonist for the long-term treatment. 8 randomized controlled trial, statistically significant reduction in vascular thromboembolism, the hazard ratio more than 50% reduction, no significant bleeding, and no survival benefit. So, vascular thromboembolism prophylaxis and treatment in patients with cancer. Low molecular weight heparin is preferred over ultra-fractionated heparin for the initial 5 to 10 days of anticoagulation for patients with cancer newly diagnosed with vascular thromboembolism who doesn't have severe renal impairment. And this is the major issue in patients receiving fondaparin because fondaparin depends to a great extent on renal clearance. For long-term anticoagulation, low molecular weight heparin for at least 6 months is preferred because of the improved efficacy of vitamin K antagonist. Anticoagulation with low molecular weight heparin or vitamin K antagonist beyond the initial 6 months may be considered for selected patients with active cancer, such as those with metastatic disease and or those receiving chemotherapy. Use of novel anticoagulant for either prevention or treatment of vascular thromboembolism in patients with cancer is not recommended at this time. So the preferred treatment is usually the low molecular weight heparin, either for treatment or for prevention. These are the guidance for managing patient beyond 6 months. What about after 6 months? The indefinite anticoagulation with cancer is while the cancer is active. And this because, as I mentioned, because as far as the cancer is active, the coagulopathy is active, the risk for thromboembolism is there, and the risk for mortality from thrombosis and embolism are there. If the malignancy is specific active malignancy, ongoing chemotherapy, this high risk for diagnosis, high risk diagnosis like lung cancer or pancreatic cancer, the previous history of vascular thromboembolism, the life-threatening pulmonary embolism, DVT with severe post-phlebitic syndrome, which also increase the risk for the development of vascular thromboembolism, and increased risk of hemorrhage is not there. So other additional risks are obesity, female sex, poor performance status, and central venous catheter. All are require continuing anticoagulation, while in patients who have higher risk for bleeding, non-life-threatening pulmonary embolism, no residual symptoms, non-active disease like diagnosis of breast cancer or prostate cancer, we favor stopping the treatment or the therapy of anticoagulation or low molecular weight heparin after 6 months. What about recurrence? For patient already on anticoagulation, if the patient on subtherapeutic dose of warfarin, change the dose to achieve the INR of 2 to 3. If INR is therapeutic, switch from warfarin to low molecular weight heparin. By the way, we are seeing this very frequent, that we usually need to shift from warfarin to low molecular weight heparin. And one of the major problems with warfarin is it's drug-drug interaction. It is a drug that catches with everything, and even with food, with vegetables, with whatsoever kind of oral intake. Patient on low molecular weight heparin, check anti-factor 10 level at 4 hours since the last dose. The peak of anti-factor 10 if the peak of anti-factor 10 is subtherapeutic, less than 5.5 units, adjust the dose of low molecular weight heparin to achieve a peak of anti-factor 10 between 0.5 to 1 unit. The peak of anti-factor 10 level is therapeutic, then increase the dose of low molecular weight heparin by 20%. If the anti-factor 10 level is therapeutic and the patient is symptomatic from vascular thromboembolism, consider inferior vena cava catheter filter. This is recommended dose for prophylaxis for enoxaparin 40 milligram once daily, for this for hospitalized medical patient. For surgical patient, 40 milligram 2 to 4 hours pre-operative, or 10 to 12 hours pre-operatively, and 40 milligram once daily thereafter. For outpatient, we recommend enoxaparin 40 milligram once daily. So, if we incidentally found a blood clot in the pulmonary artery, should this patient manage differently if this was symptomatic? What is the difference between symptomatic and non-symptomatic patient in the management? As a matter of fact, there is no difference. Both should be treated the same. Vascular thromboembolism that was diagnosed on CT scan performed for another reason than clinical suspicion of embolism, usually for tumor staging or assess the response of chemotherapy. Why we should treat them the same? This a review of 135 pancreatic cancer patient in more than 1,000 radiologic examination, and more than a third of the patient experienced vascular thromboembolism. Deep vein thrombosis was in 20%, pulmonary embolism in exactly the third, and incidental visceral thromboembolism was found in about 100%. The multivariate analysis was associated with mortality with the deep vein thrombosis with 25 hazard ratio, and the pulmonary embolism 10 hazard ratio. The incidental visceral event about 2.6 hazard ratio. So it is quite high risk either to find it symptomatic or incidental finding. Can this be prevented? Yes. Among ambulatory high-risk cancer patients undergoing chemotherapy in the United States, the prediction of vascular thromboembolism more than 17,000 cases on cancer control cohort was evaluated, and they were bladder, colorectal, lung, ovary, pancreas, and so on. And the cancer cohort have a vascular thromboembolism about 12%, 12.6% compared with 1% for the control only. The incidence range from 8% to 19% for pancreatic cancer. Is all chemotherapy the same? Of course not. There are regimens that contribute higher, especially cisplatin, which elevate the risk for coagulation factor and the release of procoagulant endothelial microplatelets, L-asparaginase, because of the depletion of the key protein in the regulation of the coagulation pathway, and the synthesis of plasminogen and antithrombin, which impaired with asparaginase-based therapy. 5-fluorouracil also is another risk because of depletion of protein C and increased thrombin activity and endothelial cell damage with potential to promote thrombus formation. This incidence increase more if we combined with GCSF. Tamoxifen and aromatase inhibitor, the risk is increased by about 3% if tamoxifen is combined with chemotherapy, and the risk increase to 15 times. Patient with vascular thromboembolism during chemotherapy had significantly worse progression-free survival and overall survival. And this clear from this study whether the patient has metastatic disease or local disease. If the patient the progression of free survival, and this was 2.5 months if the patient has thromboembolism, compared with more than almost double if the patient doesn't have vascular thromboembolism, and the hazard ratio was 3. If the patient was metastatic, the risk was higher for overall survival, again compared with whether he has vascular thromboembolism or no vascular thromboembolism. Almost the double survival. For ambulatory patient, the surgical oncology patient, outpatient with vascular thromboembolism is recommended for up to 6 weeks post-operation for high-risk abdominal or pelvic cancer surgery patient. The medical oncology patient, especially multiple myeloma, which this patient should be considered for prophylaxis, whether they have high or low risk whatsoever their condition, either in chemotherapy or not in chemotherapy. Other patient, no routine vascular thromboembolism prophylaxis recommended outside a clinical trial setting. Consider patient conversion about risk and benefit of vascular thromboembolism prophylaxis in the corona score if the patient is more than score. And this is the corona predictive model for chemotherapy associated risk. The site of cancer, very high risk are the stomach, the pancreas, high risk like the lung, the lymphoma, the gynecological, the bladder, the testicular. This tick 1, the previous tick 2, pre-chemotherapy platelet count more than 350, 1, hemoglobin level less than 10, or use of red cell growth factor, pre-chemotherapy leukocyte count more than 11, BMI more than 35 kilogram per meter square. 0 is low risk, 1 to 2 is intermediate risk, more than 3 point is considered a high risk. The prophylaxis of different clinical setting in post-operative, hospitalized patient, outpatient therapy at high risk. There is decrease in the incidence of vascular thromboembolism by this prophylaxis, almost half. And this is a recommendation is to extend the prophylaxis versus conventional prophylaxis. The hospitalized patient, as again, we recommend low molecular weight heparin versus no prophylaxis, and the outpatient therapy, again, low molecular weight heparin is preferred. For patient on chemotherapy, both ESMO and ASCO recommendation routinely not recommending routine prophylaxis if the patient are outpatient. While in patients who are myeloma or receiving Revlimid therapy, aspirin or low molecular weight heparin for low risk patient, and low molecular weight heparin for high risk patient is recommended. The same for ESMO, they consider low molecular weight heparin or aspirin for adjusted dose warfarin. For high risk patient, we should consider low molecular weight heparin prophylaxis on a case-by-case basis in highly selected patient with solid tumor on chemotherapy. We should discuss with the patient the uncertainty concerning the risk and benefit about the duration and prophylaxis and the risk of bleeding in this patient. This according to ASCO recommendation. While in ESMO, consider the high-risk ambulatory cancer patient. Predictive model may be used to identify the patient clinically at high risk for vitamin K and for thrombovascular embolization. And this is again the first slide that we show that should patient receive anticoagulation prophylaxis, I think they should, as they change the incidence of vascular endothelial thromboembolism over time in hospitalized and compared with non-cancer patient. So hospitalized patient with active malignancy with acute medical illness or reduced mobility should receive thromboprophylaxis in the absence of bleeding or other contraindication. Hospitalized patient with active malignancy without additional risk may be considered for pharmacologic thromboprophylaxis in the absence of bleeding or other contraindication. Data inadequate to support or oppose thromboprophylaxis in patient admitted for minor procedure or short chemotherapy infusion. And these are the variable for the from the RITI registration, and it is very close to what we has mentioned before, and categorize the patient as low risk, intermediate risk, and the higher risk. And for the risk assessment model that we had mentioned before, and again this is a prophylaxis that I think this is a repeated slide. This is the treatment we mentioned before. So all patients with malignant disease undergoing major surgical intervention should be considered for pharmacological thromboprophylaxis with either ultrafractionated heparin or low molecular weight heparin. Extended prophylaxis with low molecular weight heparin for up to 4 weeks post-operatively should be considered for patients undergoing major abdominal or pelvic surgery for cancer who have high risk of for vascular thromboembolism. So thrombosis and cancer, why did this occur? Because of cancer thrombosis, because of the risk. What is the influence on cancer prognosis? Usually it is poor prognosis, and actually it is really poor. What is the optimal management of this patient? Low molecular weight heparin. Should this patient manage differently from an incidental finding? No. Could this be prevented? Yes. And by this I conclude. Thank you.
Thank you, Professor Abdel, for this very elegant presentation, a very important matter في الحقيقة, and a very remarkable presentation الحقيقة. Thank you for Sanofi. يمكن يعني السؤال احب اساله لحضرتك يا دكتور عبد السلام، يمكن انت عرضت different protocols الاسكو بروتوكول والازمو بروتوكول، لكن هل from your point of view do you follow a specific protocol or guidelines for thrombophilaxis suitable for our patients and our financial resource, or we can say that there is a general guidelines ان احنا نقدر ان احنا to follow الجايد لاينز دي؟ وهل في انتي كواجولانت بريفيرد من وجهة نظرك في برضه suitable for our patients؟
شكرا دكتور عبد العزيز. الحقيقه يعني طبعا السؤال بتاع دكتور عبد العزيز سؤال مهم جدا، لان احنا بنتكلم على population 100 مليون. we can't give them low molecular weight heparin. والحقيقه cancer patient definitely at risk for development of thrombosis. ده بيقودنا لنقطة غاية في الأهمية، إن إحنا ليه ما بنفكرش why we should think differently. We should think differently using a very simple and effective mysterious drug. I called it the mysterious medication, which is aspirin. As a matter of fact, we don't know exactly how aspirin work. Aspirin work in completely numerous number of mechanism of action. One of its mechanism of action is its anti-cancer effect. Personally, I prescribe aspirin for all my colon cancer patients after therapy, and I maintain them after on aspirin while they are off treatment all the time. And the same for patients who are receiving hormonal treatment in breast cancer. And there are data which support this. It is not strong enough to be a guidelines or a part of the formal recommendation, but actually the data enough to support against any harm of using low dose aspirin in patient receiving hormonal therapy in ovarian cancer, in breast cancer, or low dose aspirin in colon cancer. As a matter of fact, I was part of a study, a very large international study led by University of Shanghai, and we found that addition of low dose aspirin after the end of adjuvant therapy in early colon cancer make a significant difference in the survival. This had been published, and it was published in the ASCO, but I don't know why it is not promoted, because it is aspirin is a orphan drug. Is an orphan drug and nobody care it. But aspirin is safe to use in low dose as far as there is no contraindication for to use it.
Thanks a lot, Professor Abdel Salam. Is there any question? I think a very clear presentation. Thanks again, Professor Abdel Salam Attia, for the elegant presentation. Thanks for all the audience, and thanks again for Sanofi. And let us to move to the next session.